So anybody who wants to read?
Antibody. An antibody panel is positive for anti-proteinase 3 antibodies of CANCA. What is the best initial treatment of this patient's condition? A. High dose steroids and cyclophosphamide. B. Cyclosporin. C. Cystoscopy. D. Plasma exchange therapy. E. Referral for surgical lobectomy or pneumonectomy.
Anybody who has any opinion about this one? So some said A. Let's go with A. So high dose steroid and cyclophosphamide. So one of you give an answer. So I'm going to go with this one. Let's see. So the answer is steroid. So the presence of antibiotics against and proteinase 3 and the clinical presentation distinguish granulomatous cholangitis along with the vasculitis. Okay, just a second. I'm going to. Okay. So now this one, untreated granulomatosis with the polyangiitis is uniformly fatal with the treatment initiation of the steroid and cyclophosphamide therapy. Prognosis is excellent and the complete remission is achieved by 75%. So this is what it is. So anybody who wants to read this one? Anybody?
Previously,
okay, go ahead.
A previously healthy 9-year-old boy is brought to the physician with 2 days of sore throat and fever. He has difficulty swallowing, rhinorrhea, and nasal congestion. He had temporary relief of throat pain with acetaminophen. The boy's immunization are up to date and has no known allergies. His temperature is 38. Examination shows bilateral conjunctival injections with no discharge. Both tonsils are 3+ and erythematous. No vesicles or exudates are present. A 0.5 centimeter tender mobile lymph node is present in the posterior cervical chain. The neck has full range of motion. Which of the following is the most appropriate next step in the management of this patient? A. Order rapid heterophile antibody testing. B. Order rapid streptococcal antigen testing. C. Order throat culture. D. Symptomatic treatment only. E. Prescribe antibiotics.
So A, D, and B. E. Prescribe antibiotics. So E. So the M centaur, try to put the M centaur and see on the basis of that what comes, what is the numbers, and then see if this needs the rapid streptococcal or prescribe the antibiotics. Symptomatic treatment only. And yeah, maybe that one could be the answer too. So D, B. So what should I go? What should I go with? B. Many of you chose B. B, E, C. So B, C. Let's go with the B and C. So the answer is D, symptomatic treatment. So the clinical feature of the patients is basically virus. It's a virus or more common etiology. Viral pharyngitis is often accompanied by the cough, rhinorrhea, nasal congestion, and hoarseness. So having this conjunctivitis with the pharyngitis, so fever, Coxsackie virus, having this posterior oropharynx. So which one was this one? Coxsackie virus. And the treatment should be analgesics, salt water gargles, and the solid drink. Not solid, actually cold drink can be offered for the symptomatic relief. In this one here. Approach to the pharyngitis patient. Clinical, you need to see all the sore throat, dysphagia or dinophagia, and pharyngeal tonsillar erythema. Presence of the viral symptoms, cough, rhinorrhea, conjunctivitis, oral ulcers, the presence of exudate, edema, and the palatal pitaki. Absence of the viral symptoms. So on the basis of that, if the viral, then viral pharyngitis, symptomatic treatment. If this has a viral pharyngitis, then you have to see negative throat culture, negative rapid antigen testing, and the positive throat culture or the rapid antigen test. So the rapid antigen test is obtained throat culture and the streptococcal pharyngitis, and then the oral penicillin or the amoxicillin. So this one. Anybody who wants to read this one? Hello, anybody who wants to read this one?
A 2-year-old boy is brought into the emergency department by his dad for a 2-day history of cough, post-tussive emesis, and diminished food intake, although he has been taking liquids. The coughing began after eating some popcorn. Mom reports that he has no fever or rhinorrhea. He had bronchiolitis at 3 months of age, but has been healthy otherwise. In the emergency department, his vital signs include temperature 37, pulse 100 beats per minute, respiratory rate 24 per minute, and oxygen saturation of 94%. On exam, he has mild nasal flaring, diffuse rhonchi, and wheezing noted to be louder on the left side of the chest. Which of the following is the best modality to confirm the diagnosis? A. Bronchoscopy. B. CT scan of the chest. C. Arterial blood gas test. D. Inspiratory and expiratory chest radiographs.
So many wrote A, D.
Foreign body.
Okay, so let's go with the A. Many of you wrote A. So the answer is bronchoscopy. Why? The foreign body aspiration. This is how it looks like. Obstructive one and unobstructive one. So right bronchus and the trachea, focal wheezing plus history of the choking and persistent symptoms, then bronchoscopy. What was the key thing here was eating popcorn. Okay, so it is the most common cause of the accidental death in the children under 1 year of the age. The risk remains under high up to 3 years. Peanuts, seeds, beans are mostly inhaled items as in small toys. History of choking and persistent symptoms with a abnormal physical exam finding like tachypnea, retraction, wheezing, stridor, unilateral breath sounds, or cyanosis should be evaluated for the foreign body aspiration. Bronchoscopy is the gold standard for the thing. Anybody who wants to read this one?
A 27-year-old woman comes to the physician with a dry cough for the last 2 to 3 weeks. He also reports malaise, intermittent fever, and various joint pains. Physical examination shows tender erythematous nodules on the anterior surface of both legs and a small right-sided ankle effusion. Cardiopulmonary examination is normal. Chest X-ray reveals bilateral hilar fullness, but no pulmonary infiltrates. Which of the following is the most likely diagnosis? A. Primary HIV infection. B. Rheumatic fever. C. Sarcoidosis. D. Still's disease. E. Tuberculosis.
So many have you been choosing C. So let's go with the sarcoidosis. The answer is sarcoidosis. The fever, migratory arthralgia, erythema nodosum, hilar adenopathy, and the Lofgren syndrome. So the variant of the sarcoidosis. Lofgren syndrome is common in the young and generally seen in the favorable prognosis. So the clinical presentation, the diagnosis may be seen clinically, does not require tissue confirmation. So controlled with the NSAIDs while awaiting spontaneous remission. Okay. So the next one. Anybody who wants to read this one? Anybody who wants to give it a read for everyone?
Yeah, I will.
Okay.
A 13-year-old woman presented to the emergency department with acute chest pain and shortness of breath. She was in high-speed motor vehicle collision approximately 2 weeks ago and had a lower leg fracture that was repaired. During her stay in the hospital, she developed a deep vein thrombosis and was treated with enoxaparin initially before transitioning to dabigatran. She was discharged from the hospital 4 days ago. On examination, her pulse is 126 per minute, BP is 104/70. Respiratory rate is 32 and temperature is 37.6 degrees Celsius. Her chest radiograph is clear. Her ECG shows sinus tachycardia without ischemia. Laboratory value shows leukocyte count 13.4 into 10 raised to 9, hemoglobin 112 gram per liter, platelet 62 into 10 raised to 9, prothrombin time 12 seconds, activated partial thromboplastin time 30 seconds, D-dimer 916. She has normal kidney function and her troponin is within normal limits. And what is the most likely diagnosis?
So immune thrombocytopenia, DIC, heparin-induced thrombocytopenia, or TTP. So C, okay. C, anybody else? C. Since many of you have been giving answer C, let's go with the heparin-induced thrombocytopenia. Let's see the answer. So the answer is heparin thrombocytopenia. This one is it. The immune complication of the heparin therapy, low molecular weight, heparin antibiotics, and this is exposure after 1 to 2 doses, and platelet drop to approximately 100 into 10 to 9 is not associated with a thrombosis. Patient should continue the use of heparin, okay? Then with the significant, typically HIT type 2, approximately 5 to 10 days, presents with a thrombocytopenia after initiating heparin. So the first type 1 is in 1 to 2 doses. The 2 one is 5 to 10. So this is a very nice thing, the differentiation between the both of them. Then the complications is skin necrosis, lymph ischemia, organ ischemia, infarction, sign and symptoms of acute pulmonary embolism. She recently started taking heparin. The clinician should consider HIT and first on the differential. So HIT should be moderate instead of severe thrombocytopenia. Coagulation studies within normal range, PT and APTT. So this is a very nice table of the type 1 and type 2. Type 1 is 10 to 20%, type 2 is less than 3. So 1 to 4 days, this is 5 to 10 days after heparin, or less than 1 day if prior heparin exposure within last 30 days. So usually more than 100, this is more than 20. So outcome, this has none, and this causes thrombosis, necrotic skin problem, and acute skin reaction. So what are you going to do with continue heparin and observe? So this one contains more like skin necrosis and thrombosis, so you have to stop heparin right away. Alternate coagulation with maybe DUAC or something to prevent the thrombosis. Okay. So the next question, anybody who wants to read this one?
A 9-year-old boy presents with a 2 days history of rash. The rash started on the head and spread downwards to his trunk and extremities. He also complains of a fever, cough, and a runny nose for the past 5 days. On physical examination, his temperature is 38.2, blood pressure is 88 by 56, pulse is 76 per minute, and respirations are 16 per minute. There's a small irregular red spot with a central gray color on his buccal mucosa as shown below. The rash on his body is erythematous and maculopapular in quality. Which of the following is the most likely diagnosis? A. Erythema infectiosum. B. Hand-foot-mouth disease. C. Measles. D. Roseola infantum. E. Rubella.
Coplic spots, so it's measles.
So this is how it looks like. C, many of you said A, C. So let's go with the C. The answer is measles. So how does the Koplik spots look like? This is the Koplik spots having this white thing, okay? So this one here, measles is a contagious and exanthematous respiratory infection. So direct contact with the droplets, like respiratory. Contagious for the 1 to 2 days before the onset, 4 days after the appearance, and then the cough, coryza, conjunctivitis, discharge, fever, Koplik spots, the blue-white spots, and begins at the hairline, down the trunk, and the brownish discoloration, desquamation. So they are telling you what happens at the first day, then second day, might be fourth day, all of this fever, and then lymphadenopathy, diarrhea, vomiting, splenomegaly are the common features. Therapy is largely sportive and the symptom based. Okay. Anybody who wants to read this one?
A 4-year-old girl is brought to your office by her mother because of her skin lesion. The girl noted that the child has multiple mosquito bites in her arms and legs but did not treat them. They got alarmed when she developed blisters at the site of the insect bites. Many of these have ruptured to leave VP crusted areas that the girl persistently scratches. The mother also noticed that she had become weak and has been febrile for the past 2 days. Her vitals are normal. Physical examination of the skin of the trunk and extremities. There are multiple moist VP denuded circular areas with yellowish purulent crusting, peripheral scales, and small bulli adjacent to them. Bulli on the erythematous base are seen interspersed between the circular patches. There are also many excoriations. In addition to an oral medication, which of the following is the most appropriate therapy? A. Azelaic acid. B. Fluconamide. Flucinonide. C. Hydroquinone. D. Ketoconazole. E. Mupirocin.
Okay. So many of you
Secondary bacterial infection,
E.
mupirocin.
So there has a multiple mosquito bites and these things. Anybody who has any other opinion? Okay. E. E. Okay. Let's go with E. The answer is muprosine. So this says variant of the impetigo include. So I'm going to open one by one so you can see. So the impetigo is basically contagious bacterial infection. Less common manifestation includes the bulla impetigo or the ichthyoma. So impetigo can be followed by the post-streptococcal glomerulonephritis or the rheumatic fever. So how does the non-bullous look like? This is how the non-bullous look like. No bulla formation, okay? Just the pain and everything. Then coming to the bullous, it has bulla here. Bulla. Okay. Now moving on to the next one, ecthyma. This one is ecthyma. Okay. This is a very nice picture. You can see how does they look like. Okay. Then they said this is all the young children's having this insect bite. So what are you going to do is basically starting from the ground stain and culture. Then the treatment, oral semi-synthetic penicillin or the cephalosporin is recommended. Topical is basically muprosine or ritamapulin. So this muprosine is applied 3 times a day and ritamapulin is applied twice. The recommended length of the treatment is 5 days. So hand washing, so this is all the prevention, hand washing. In addition, children can return to school in the 24 hours after beginning. An effective antimicrobial therapy. Training patients may be kept covered. This one here. Okay, anybody who wants to read this one? Anybody?
A 46-year-old woman presents with a 6-month history of fatigue and generalized pruritus. Physical examination reveals hyperpigmentation of the skin and hepatomegaly. Lab findings reveal hemoglobin 138, mean corpusculum volume 89, leukocyte count is 7300, total cholesterol is 5.8, liver function test alkaline phosphatase is 225, antimicrochondrial antibodies is 1:160. Which of the following is the best next step in the management of this patient? A. Methotrexate. B. Urodeoxycholic acid. C. Azathioprine. D. Liver transplantation. E. Glucocorticoids.
Many of you have been saying B.
PBC.
Okay. So this should be oxycholic acid. The answer is this. So this is PVC. Cholestasis, alkaline cholesterol, and elevated serum IgM, antimicrobial antibodies, and the risk of hepatobiliary malignancy is elevated in those patients diagnosed with the PBC. Urodeoxycholic acid is the drug of choice. It shows slow disease progression and relieves symptoms. Patients taking UDC are monitored with the liver biochemical test. So improvement typically occurs within 6 months. So this is the thing. The only curative treatment is the liver transplantation. Okay. This one is here. So this one, the liver transplantation should be, when should be the liver transplantation is recommended? Serum bilirubin exceeding 6 mg. So I'm reading this one when you are going to do this one. Decompensated cirrhosis as an unacceptable quality of the life and the anticipated death within the years. So it should be strongly considered liver transplantation. Just reading for your information, okay? Okay, anybody who wants to read this one? The psychiatric question. Anyone?
35-year-old man is admitted to the psychiatric temporary observation unit complaining of depression and suicidal ideation following a cocaine binge. During his stay, he starts feeling as if insects are crawling under his skin. This is most typical of which of the following phenomena?
Formication.
Depersonalization, dyskinesia, formication, illusion, synesthesia.
Many of you have been writing C as a formication. So this is the typical definition of the skin crawling under the skin. So formication is the tactile hallucination. Okay. Let's do this last two and then anybody who wants to read this one, kindly do it quickly.
A 62-year-old man complains of inner itching and discomfort, particularly towards the end of the day. He works as a salesman in a departmental store where he has to be on his feet all day. When he goes home in the evening, he finds himself sitting sideways to avoid the discomfort. He has no fever, rectal bleeding, or soiling of his underwear. and he never had surgery in that area. Which of the following is the most likely diagnosis? A. Anal fissure. B. External hemorrhoids. C. Fistula in ano.
Abscess.
D. Internal hemorrhoids. E. Perirectal abscess.
Abscess.
Okay. Anybody else who has any opinion about this one? External hemorrhoids. Okay. B. D. E. Okay. Anybody else? B. B. Any more opinions? Okay. Let's go with the B then. It was B, right? That's what you
No, this is wrong.
Okay, whatever you guys say, let's go with that. How many people said B?
E.
1, 2, 3, 4. So 4 people said B and the 4 people said E. Any one more opinion? I will go with that one. Anyone?
B.
Okay, let's go with the B. So the answer is
There is no fever. There is no fever for an abscess.
yes. So the hemorrhoids are the swollen blood vessels in the lower rectum. They are most common cause of the anal pathology. Like internal hemorrhoid bleeds but do not hurt. The external hurt but do not bleed. This is a typical symptom. So why not the abscess? Maybe caused an intense pain along with the fever. Okay. So short clinical course ending with a spontaneous discharge of the pus. So needs to be the drain. So the last one, anybody who wants to give it a try?
54-year-old man comes to the primary care clinic due to cough and cold symptoms. He is afebrile and his lungs are clear. The physician explains that antibiotics are unlikely to be effective and explains their risk and potential for the development of antibiotic resistance. The patient responds angrily, "I know the nurse kept me waiting on purpose, and now you want me to see if I'll get sicker. Doctors just want to make money." The patient has never been hospitalized for psychiatric reasons. He lives alone and has inconsistent work history due to repeated conflicts with co-workers. Which of the following is the most likely diagnosis? Delusion disorder, paranoid personality disorder, antisocial personality disorder, schizoid personality disorder, typical personality disorder.
Okay. So C and D. Now again we have two options. Okay, C. So I'm going with the C and we can see it from there, okay? So the answer was B, okay? The explanation, just a second. So how many you guys corrected? 1, 2, 3, 4, and the 5, 6, 7, 8. So 8 were wrong and the rest were correct. So the answer was a paranoid personality disorder. The patient's distrust and suspicious long-standing pattern of the interpersonal problems at a work suggests paranoid personality disorder. The patient with a paranoid personality disorder exhibit a pattern of the pervasive distrust of the others, and in early adulthood. Although delusional, these patients interpret the motives of the other as the malevolent. So this is very complicated in English. You can just stick with what you know, okay? Read hidden meaning into the benign comments and events and easily angered and bear grudges regarding minor slights. Such patients are challenging and it is often difficult to build a physician-patient relationship with them when confirmed in the paranoid interpretation. The patient must not be non-defensive and can attempt to diffuse the patient anger by providing clear and the direct explanation. So this one is very nice. Paranoid personality. The suspect. Pervasive pattern of the distrust suspicious beginning in the early adulthood and occurring in a variety of the setting. So this one, so risk factors is family history of schizophrenia or delusion or paranoid, and the treatment is CBT. Always remember in personality, do never give any medication. Okay. You have to bring the insight in the patient. One of the very, very important thing in the personality is basically when somebody like either brought by somebody or either the patient is coming with something else and you are figuring it out. The patient himself is not aware that what is he is having. Like in particular other condition, the patient himself is aware of this thing. But here this personality, he's living with it for this whole life. Okay, so this is it. As promised, I have done ACE with you guys. So let's do tomorrow some ethics question. Okay.